One of the commentators from a recent video pointed out that there was another case in Canada where a man died in the emergency room, similar to the case of the recent one in Edmonton, Canada, where a man who came in with chest pain collapsed after waiting for 8 hours. In this video, we'll go over the process of what happens when you come into the emergency room and what does the hospital do after an event like this. And health authorities have said that the case is under review, and that's normal in situations like this. There was another widely reported case occurred in Winnipeg where an Indigenous man died after spending more than a day without being formally triaged. That's unheard of. If you enter an emergency room and you're not triaged, something drastic happened. But I wanted to be very clear from the start. The video is not about blaming individual doctors or nurses or any hospital staff. It is a system problem. Rather, it's about understanding how emergency departments work and what the data actually shows, and why these cases raise serious system-level questions. After high-profile cases like these come out, people ask the same question. How does something like this happen? What went wrong? Is there any accountability? People do die in emergency departments in both countries. Now, fortunately, they don't happen often, but it doesn't mean that they never happen. These cases feel so shocking is because most emergency departments' deaths are never publicized. They're usually handled quietly through internal review processes. And let's look at the data and how often these unfortunate deaths happen. Neither Canada nor the United States publishes a simple public number that says, well, how many people die in emergency rooms each year? Instead, deaths are tracked across national health systems. At least they're tracked, right? In the United States, information comes from sources like the Centers for Disease Control and Prevention, CDC. They record place of death along with hospital quality databases. In Canada, similar data is collected by the Canadian Institute for Health Information. They analyze this data. They consistently find that death occurring inside the emergency is rare on a per visit basis, usually fewer than 1 per 1,000 visits. What that tells us is that emergency departments save lives every day, but adverse events could happen. It also tells us that rare outcomes still happen, especially when systems are under enormous pressure. Emergency departments see millions of patients every year. Our emergency room was packed most of the day and night. So even rare outcomes, especially during periods of crowding, long waits, or staff shortages, most emergency department deaths are not dramatic scenes, just like you might see on television. What they often involve is prolonged waiting, several hours, delays before triage or reassessment. And one important thing that people may not recognize is that while you're waiting, your symptoms may evolve, or conditions that don't look severe at first may become severe. Cases like Winnipeg draw attention because triage and reassessment are foundational to emergency care, and I can attest to that reassessment part. When those processes are delayed for any reason, risk increases. Reassessment is so important because of those reasons. People who come in not as severe may become sicker while waiting for hours in the emergency room. Now, when there's a lot of people, that may take a little longer. That's why having adequate staffing is so important. And as is the case with the man with the chest pain in Edmonton who collapsed, it's especially important when we talk about chest pain. Not all heart attacks look the same. A STEMI is loud. It shows up clearly on the EKG. So then it notifies the staff there's something happening to your heart. But a non-STEMI can be quiet because the EKG may look normal early on, and damage only appears later on blood test. That means someone can look stable while still being at risk. Based on the family member's comment, the Edmonton man was complaining of chest pain throughout his 8-hour wait. In busy emergency departments, timely triage and repeated reassessment are critical, especially when people are waiting. This is why chest pain cases often appear in safety reviews, not because someone did something wrong, but because time, monitoring, and system flow matters. When someone dies unexpectedly, hospitals don't simply move on. In both Canada and the US, these cases typically trigger formal internal quality and safety reviews, sometimes called sentinel events or critical incident reviews. These reviews examine wait times, whether triage occurred, whether reassessments occurred, what was the staffing levels during that time, and what was the communication like between the triage area and in the department, and overall system processes. As a public, we're not going to know the outcome of these cases. People often ask, if these cases are investigated, why don't we have access to the results? These are legitimate questions. There are very few important reasons why they're not available publicly, and they're mostly about how healthcare systems are designed. First, these reviews include protected medical information, patient records, timelines, and staff statements, all covered by privacy laws. And second, these investigations are designed as quality improvement tools, not public report. Their goal is to identify system gaps and prevent future harm, and not to assign blame. And that's important for these reviews, because staff are more likely to be candid when reviews are protected from becoming legal or disciplinary documents. Remember, it's about quality improvement. And finally, releasing partial or technical information too early can create confusion or fear, especially before all the facts are collected or verified. So when the public doesn't see a full report, it doesn't mean nothing happened. It means the review happened behind closed doors, balancing transparency and privacy, as well as fairness. Both countries have very similar emergency department death rate when you look at risk per visit. The biggest difference between both countries isn't the risk, it's visibility. In Canada, provincial health systems are sometimes more likely to release public summaries, especially after high-profile cases like those in Edmonton. Now, in the United States, similar reviews happen, but they usually remain internal unless regulators or family members release information. All staff are made aware of the reporting protocol, what's involved once you are part of that internal review process. Hospitals take these things extremely serious. And as individual healthcare providers, doctors, nurses, respiratory therapists, technicians, we're there to make sure the patient does well. So when these things happen, like a sentinel event or an adverse event, particularly when someone dies during our care, it impacts us greatly. Thankfully, emergency rooms deaths are uncommon, but when they happen, they deserve careful review, honest discussion, and public trust. In closing, this video discusses publicly available information and national health data. It does not allege wrongdoing by any individual or institution. Emergency departments do save lives every day, but even strong systems can fail under pressure because it's run by humans, and we are not infallible. Thanks everyone for watching, and stay tuned for more information, what happens in emergency departments and what happens during a sentinel event. Bye-bye.